Welcome to BrainMatters, the show about all things neuroscience. Whether you're a seasoned academic or just curious about the brain, our guests will be covering everything from cutting-edge research to practical tips for improving our mental health. I'm your host, Thomas von Rijn, and today I'm joined by Professor Teresa Schuhmann, Principal Investigator of the Clinical Neuromodulation Group at Maastricht University, here to discuss the role of transcranial magnetic stimulation in the treatment of mental health. Professor Schuhmann, welcome to the show.
Thank you very much. I'm happy to be here.
Could you start out by telling us a bit about yourself and the path that your career has taken over the years to get where you are now?
I'm Teresa Schuhmann. I'm a professor of clinical applications of non-invasive brain stimulation. And I actually started off as a psychology student here in Maastricht. Very convinced that I'd be interested in more forensic psychology. But throughout my studies, I actually realized that I really like cognitive neuroscience. So I did a PhD in cognitive neuroscience, already starting then with working with non-invasive brain stimulation. Then I was actually interested in language production, and I was interested in whether to study language production, what is happening in the brain with TMS. And throughout my career, I actually changed field a little bit. I always stayed true to non-invasive brain stimulation, but I actually got interested in more applied in more applied areas. And finally, I ended up in actually looking more into the clinical applications of non-invasive brain stimulation.
Wonderful. So I think for this conversation, we should start at like the bare bones, and then we'll build our way up to where we are today. So how does TMS work? And what disorders is it being used for at the moment?
So TMS stands for, as you were already saying, transcranial magnetic brain stimulation. And what you have to think about when we work with transcranial magnetic brain stimulation, it's a tool that is non-invasive, which means we actually don't open the head. We do everything from outside. And we work with electromagnetic coils. So these are coils that in which an electric current runs. And if you still know a little bit about physics, a changing electric field actually induces a changing magnetic field. And this magnetic field kind of painlessly goes through the skull, and in the brain it turns into an electric field again. This enables us to actually stimulate neurons. So we can induce action potentials from the outside with putting a coil on a person's head. How can this be used? So it can be, of course, used just for basic research to figure out more about the brain, because we can stimulate areas and we can see what people are still able to do. But it can also be used clinically, which is actually very exciting, because in the last 20 years, we've learned a lot about TMS, and it's used for psychiatric disorders such as depression, but also obsessive compulsive disorders. We also use it for anxiety. So there's a whole range of psychiatric disorders as well as neurological ones where TMS can be used as treatment.
Okay, you mentioned there that you can stimulate certain regions. And obviously neurons are tiny and some clusters of them are very small. How precise is this in stimulating brain regions?
So we have very different kinds of coils. So we have larger coils and smaller coils. We have coils that can stimulate deeper areas and more superficial areas. But if we're actually talking in neurons, I'd say TMS is a very imprecise method, because we always do stimulate a rather big area. So probably about 3-4 square centimeters. So rather big. What adds to that is that we actually don't just stimulate that area, but that we also get connectivity or network effect. So we stimulate one area, but of course neurons then fire, and there is connections between neurons. So actually, if we stimulate one area, other areas are also affected. So it's not a very precise method.
So from the patient's point of view, what does a TMS protocol look like at the moment?
So this is actually quite nice, and there is a lot of development in the last few years. But if we think about the first kind of TMS treatments for depression, so what you get is that patients actually come to a clinic and they get the TMS coil on their head. You do some measurements to know where you have to stimulate, and then they're stimulated between, I think nowadays it's generally 20 minutes. older protocols, they were stimulated for 40 minutes. And you do this for 5 days a week, so weekend is always off. And then ideally you do this for 6 weeks or maybe even 8 weeks. So every day the patient comes back for this treatment. This is the original protocol. Nowadays, we also work on different kinds of protocols where patients actually come for a shorter time, but then we actually stimulate them more times on one day.
Is there no safety precautions with something like this? Just going from doing very short sessions over a long period of time to ramping it up over a short period of time?
Well, actually, we did quite some nice research on that. So there are, of course, side effects of TMS, which include, for example, headaches, or what we see is that people sometimes get rather tired when they're within a course of TMS. Once we started increasing, we were worried. We were wondering whether this is still safe, but we have a lot of data now showing that surprisingly, we can give many, many sessions of TMS a day, and it's still very safe for patients.
Now, with other sort of oncoming potential first-line treatments for depression and other disorders, they have longer term benefits after the initial treatment session. Is there something similar with TMS?
Mm-hmm, mm-hmm. That's very similar, and maybe also a good point, because what we see is that depressive patients, there's still a large number of patients who do not react well to standard antidepressant treatments such as medication or also cognitive behavioral therapy. So this is how it actually started off with TMS, that we had these what we call treatment resistant depressive patients. They were just not reacting well to medication and standard treatments, so we tried to give them TMS. And it was fantastic to see that these patients actually reacted well to TMS, and we saw quite some improvement in their depressive symptoms. Of course, the idea is not that we only stimulate patients for 6 weeks and they're not depressed in those 6 weeks, and then afterwards they are depressed again. So there's a lot of data showing that this actually the antidepressive effect lasts much longer. And this is really depends on the patients. For some, we actually see some patients who really remit, so who really don't have depression afterwards anymore. Others, we see that they remit for a while, but they need some maintenance treatments, for example, after half a year or a year again. So it differs between people, but of course there is also long-term effects. So it's not just during the stimulation itself that they improve.
Okay. Now, in reading a little bit about this, there was talk of inhibitory effects, excitatory effects. How does that work when you're just sending waves at the brain?
That's a very good question. So indeed, when we work with TMS, we can of course give one single pulse, and this is a little bit of what I explained earlier on, how we give the magnetic pulse into the brain, and there is an electric current then turning into action potentials. However, when we treat patients, we use different kinds of protocols. You often hear them called being high frequency or low frequency protocols. So, for example, you could think of a 10 hertz protocol where patients get pulses 10 times a second. So it's like a dit, 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 dit. It sounds like this. And we know that these protocols actually induce long-term potentiation if it's an excitatory protocol, or long-term depression if it's an inhibitory protocol. So you can actually make an area more reactive, more excited, and another area more inhibited.
What direction, from your position as a TMS researcher, would you want to see research and clinical use of TMS go in the next decade?
Well, first of all, I'm extremely excited to see where TMS has been going in the last few years, because we have known for a long time how well TMS works for depression treatment. But I think there's already publication in the very early 1990s showing that it works. But only in the last few years, we actually use it as proper treatment for patients, because it takes so long to actually, for example, get FDA approval. And then the next step for health insurance is to pay this treatment. So I'm already very excited to see where we are now. That depression treatment with TMS is actually happening in many countries now, and more and more health insurances pay for it. So actually more and more patients have access to TMS. And this is a very recent development, so really only in the last few years. So this is already what I'm extremely excited about. I'm now very much looking forward to seeing the treatment for other illnesses, such as obsessive compulsive disorder, or also some neurological disorders, or for neurorehabilitation. I really hope that the development will go a bit faster here, that health insurances will also start paying treatments there. So this is the one thing that I'm first of all excited about what has been happening. For research, we can just take it. We're learning an enormous amount. So 20, 25 years ago, not that many people were working with TMS. Now you see there is an explosion in publication, in researchers. So we start to learn much more. We're looking in animal models. We're looking in other modelings. So there's an enormous amount of research happening, and we learn more and more. And a lot of the things that we assumed, we know are not true anymore. We also, it's a very nice example that we always said, well, for TMS, we actually, in basic research, when you use fMRI, you see correlations, you see areas in the brain that are active, but you don't know whether these are actually necessary for certain tasks. And we always said TMS is great because we actually get causation here. Because if we stimulate an area and people cannot do that task anymore, we know that this area is actually necessary and the area that's needed for this task. So we use this term causality a lot, which is now not done anymore because we know that TMS effects are not local effects, but they're actually network effects. So this arrogance we had saying we can show causation, we don't have this anymore. Same counts for this inhibitory and excitatory effects. We're learning more and more saying, well, is it really that this one protocol is excitatory and the other one is inhibitory? Because a lot of the things that we know about TMS are actually based on motor cortex stimulation. Because if you stimulate the motor cortex, you can very nicely see what's happening. Because if I stimulate the motor cortex, I get a response in my hand. If I stimulate the hand knob, for example, and I can actually see if I apply a certain TMS protocol to the motor cortex, I can see whether I see an excitement afterwards, so that it's more easily to get a finger movement, or whether I induced an inhibition, saying it's harder to now get a movement of the finger. But we actually don't know too well how this works on other areas. So we're noticing now that we oversimplified in the past, and we're just learning about how this works exactly. And also in the clinic, we noticed that there's this whole discussion on how specific you have to be with the stimulation. So do I really have to be in this one little area? And if I'm 1 centimeter next to it, do I actually have such a nice clinical response, yes or no? And for many years, we were working on getting better and better and better localizing areas that we want to stimulate. We scanned before, we did resting state analyses, we did connectivity analyses, and then we used neuronavigation, so we knew exactly where to hit and treat. But now there's studies coming out that say, well, even if I don't do this, I get very good clinical response. So maybe this is not necessary. Then there's discussions, this protocol works, but this one actually also works. So I was recently at a conference where we were discussing, are we actually going the right way? Like, to perfectly define the area, is this necessary? Or could we theoretically also stimulate with a very non-focal area? So we actually stimulate a big area of the brain and we would have the same clinical response. So I'm extremely excited to see where this is going. And I also love, I think, in the field of non-invasive brain stimulation, you really see how science works, that we were convinced of something, but then we do more research and we actually learn more and adapt our idea. What stays, even because this is a very researchy questions, because I also do a lot of research. I don't just do clinical treatments, of course. What stays is that we see a great clinical effect.
What does an animal model of TMS look like? Is there like a tiny coil that you put on a rat's head?
Yes, exactly. So this looks very cute because there's tiny coils for animals. Exactly this. We have tiny rat coils, mouse coils, where you can actually stimulate rats and mice brains.
Okay,
Yeah.
I need to look that up. That sounds
You should
amazing.
look that up. I have pictures of my little daughter when I was in my first conference and she was a baby, and I put one of those baby coils on her head. It looks very cute. It was an animal coil, but they are cute.
And you mentioned something there neural navigation?
Yes, neuronavigation.
Like, what is that?
Yeah, that's a good question. So what you could theoretically do is you could just put the coil somewhere on the head and stimulate. If I put it on the motor cortex, I see very nicely that I'm on this good area, because if I give a pulse, I see a response in my contralateral hand. If I go for other areas, this is a bit harder. And I can, of course, say, well, I know approximately, the EEG, electroencephalography system. You have these caps and there are different positions. And well, there is this one position, F3. And if I stimulate or if I go there, there's generally, on average, over average, there is the dorsolateral prefrontal cortex under that. But you could also say, well, this is on average, but I don't know with this particular person. So I actually want to have a scan of their brain. So I put people first in the scanner, I scan them, and I can either have an anatomical scan, so I just see what the brain looks like, or I could actually also have people do tasks. So I can have a functional scan, so I see which areas are active during a certain function. And then I take people out, I do some analyses, and I can also make a reconstruction of the person's head and the person's brain based on this scan. Then I can use a neuronavigation system, which is really a system, like a tracking device, a little bit, where I track the head of a person and I track their location in space, and I also track the coil that I want to use. And I co-register the reconstruction of the brain and the head of the person with the person in real space, with the head in real space. So then I actually see online, live, where I am with my coils. So whether I'm exactly over that spot where I want to be. This is called neuronavigation and neuronavigated TMS.
Sounds very full on. Finally, I wanted to talk to you because of your recent partnership with, is it a psychiatric organization, Mondrian, over in Maastricht and Helen nearby.
Mm-hmm.
Could you tell me a bit about this partnership and what you're hoping to do there?
Mm-hmm. So, like I said, I'm a psychologist by training, but actually by proper deeper training, I'm a cognitive neuroscientist. So I don't really treat patients myself. I don't have the education for that. But I have a tool that can treat patients. And I really want to make sure that this tool is being used. And because of this, we collaborate a lot with clinics around us, with neurologists and psychiatrists. And Mondrian, indeed, it's a psychiatric healthcare facility that offers psychiatric treatment for the area, for Limburg. And within this facility, there's also a center of expertise. And this center of expertise is actually like an innovation center, and they're trying to introduce new treatments within the clinic. And indeed, I've recently become a professor, and I work one day a week. I actually work at Mondrian, and what we're trying to do there is actually getting the use of TMS there. So we already have a little bit of a TMS room down there where we treat OCD patient, obsessive compulsive patients. And every now and again, we also treat depressive patients. But we actually want to make sure that this is going to be standard care also within Mondrian. So my role is there actually explaining to the psychiatrists and psychologists why TMS is a good therapy to have. We're looking where it makes sense. We're currently, for example, discussing which are great patients where we could use this. And then I actually train the people and help them to set up the TMS in their clinic. One big field where we're also thinking about using this, for example, is for depression treatment in the elderly. You might know that elderly are a bit of a harder population to treat for depression. So elderly psychiatrists are often looking for new ways of treatment. And this is also one of the ideas that we have, that we say, well, maybe we could integrate a TMS clinic also in the elderly psychiatry within Mondrian.
Okay, so you're getting involved in making the treatment as widely available as possible.
Exactly, yeah. I think this is one of the nice things if you're a basic researcher and you kind of take this step into how we can do clinical applications, because this is one of the nice things if you're a researcher, that you also want to have an impact or make a difference. And I think TMS offers a beautiful opportunity for this.
That's amazing. So, before we wrap up this conversation, I have some light-hearted questions that I would like to ask you to get a glimpse of the person behind the scientist. Does that sound good?
Absolutely, yes.
Since you're in Maastricht, do you ever frequent the weekly marked markets?
Actually, rarely, because I work a lot. I
Yeah,
only do this when my mom is visiting, so then I go with her on the Friday morning market.
Oh, does Mum have a favourite stall?
On the market, yeah, she
Yes.
loves the cheese stall.
Ah, as in the classic Dutch gouda, or
Well, the classic Dutch boerenkaas.
okay.
Hmm. But whenever I go with her, I think, oh, I should go every Friday. But then work makes it a bit tough to go there on Friday mornings.
Understandable, I'm sure. If you only needed half the sleep that you do now, what would you do with that extra time?
I think I would love to read more. I used to read a lot, and now I have 3 children and a job and a household to run. So sometimes the time for reading is very little. So I think if I only had half of the sleep, I would actually read more.
Is there a genre of choice?
No, I love to read many different things. So mainly I read books I get as presents because so I really try to tell my family or friends to give me books that they like. So it can be very different genres.
So it's been a long day at work. You got no dinner at home. What's the go-to takeaway order?
Oh, that's a good one. Yeah. Uh, this is a very common thing at
Especially
our
with 3
house.
kids at home.
Exactly. I think the go-to order is either sushi, or if it's Friday, my kids, even though I'm German and we're a German household, my kids grew up here and they convinced me that Friday is the chips night. So we actually go to the local friture and get chips, fries.
Okay.
Yeah.
Is that a Dutch tradition?
Apparently they tell me it's a very Dutch tradition, and I think it's a bit true because on Friday the friture is completely full.
Okay, Frituur Friday. I can
Friture
understand
Friday.
where it comes from.
They actually call it Frittevrijdag.
Ah,
Yeah.
so we've covered a lot, and I think you've given people a really good introduction to both TMS and your work. While you have the platform, is there anything that you or your lab is doing that you would like to promote?
Yeah, what I'm really proud of is work that I actually did, because you probably heard that my title is non-invasive brain stimulation and the professor title. So we're not just talking about TMS, but we're also talking about other forms of non-invasive brain stimulation. And I actually also work with transcranial electric stimulation. And one of the forms I work with is transcranial alternating current stimulation, which works a bit differently. So it doesn't work with magnetic fields, but it actually just works with pure electricity and electrodes that can also go in a certain frequency. If we talk about TACS, transcranial alternating current stimulation. And there you can also stimulate the brain in a much weaker form than with TMS, but we see really nice cognitive effects here too. And you can actually entrain frequencies. So if I stimulate with a 10 hertz TACS protocol, I actually see that I see an increase in these alpha frequencies. And I really love this method because it's a very easy method to use. So you don't need as much training as you do with TMS. It has even less side effects, and it's a method that can theoretically be very easily used at home as well. So we're always trying to find things that are easy for patients to use. And I did a very exciting study together with together with a group of people, of course, but it was run by my PhD student Marij Middag, where we actually used TACS in people who had a stroke. People who have a stroke have all kinds of symptoms afterwards. Probably the ones that you see most are paralysis if you see it and walk around in town. But there's actually one thing that is extremely exciting, which is called neglect, visuospatial neglect. These patients have a stroke. It's often on the right hemisphere. And what you see is they start to ignore half of their world. So the area that's contralateral to the side where they had the injury, they just don't, it's not a not seeing because they can still see, but they ignore this. Meaning they don't shave this side of their face. They don't put the glasses on properly. They only eat half of their plate. So they completely ignore the left side. They walk against things that are on their left side. And it's actually something that we see a lot after stroke, but a lot of people just spontaneously recover.
So all the senses are there. There's just no conscious registry of the left side of their life.
Exactly. Yeah. So they don't pay attention to it. They had no conscious awareness of this left side. It's quite an interesting thing. And these patients, so many spontaneously recover, and a lot of treatments have been developed. But some people, you see, they don't get better. And we did some really nice basic research here in the labs, because this is really an attention deficit. And we did some research in the lab with healthy people that we saw, well, if we stimulate them with TACS, healthy people, we actually see that we can move their attention from one side to the other, even in healthy people. And we thought, well, this is great that we can do this. Maybe we can also try this in patients, and that we don't just do one session like we do with healthy people, but that we actually also do repeated sessions of TACS in patients. And we ran this study in chronic patients, so neglect patients who've really tried everything, but nothing helped. And we combined this with a standard, they often get these visual scanning trainings where you kind of teach them to move their attention. And we treated them for 6 weeks with TACS combined with this training. And we actually saw an improvement in their attention. So we actually saw that we managed to move their attention to the left side, to the unattended side. And this was still there 3 months after the treatment. So this just recently was published, and it's probably one of the studies I'm most excited about. And I'm very proud of my PhD student, Marij, who traveled the whole Netherlands to treat all these patients. But this is very exciting. And since TACS is such an easy method, I very much hope so that eventually we can actually introduce this in neurorehabilitation clinics.
Now that's exciting. Which makes my next question more important. If people wanted to reach out to you, either for collaboration, discussion, potential work, where could they do so?
Mm-hmm. They're very welcome to email me. So my email address can just be found on the internet. And that's
I can also link to it.
You can link to it. Perfect. And they're very welcome to contact me. Yes.
Wonderful. Teresa, thank you so much for your time today.
You're very welcome. Thanks for having me.
If you enjoyed this discussion and want to learn more about the brain, why not check out our website at brainmatters.nl, where you can find easy-to-follow articles in both English and Dutch to satisfy your curiosity. Until next time.